Thank you again, those of you joining us today for our Friday Healthy Conversations series. We've been doing this every week, every Friday at noon, with a different wellness expert, healthcare provider, lots of different folks talking about how to live better, live well with diabetes, or whether you're managing diabetes or any chronic condition. We are here. We are joined today by Dr. Roberto Ortiz, and I'm going to turn it over to him in just a moment. First, I want to let everyone know that we are recording this webinar. We're also streaming it live to the Ripen YouTube channel. And you can ask your questions, Dr. Ortiz. If you have any questions, feel free to type them into the chat here on Zoom. You can click the Q&A button if you're on Zoom, type your questions in that way. You can also type your questions in the chat on YouTube if you're watching us there. And I can relay them to Dr. Ortiz, who will do his best, I'm sure, to answer them. So with that, I think I'm ready to turn it over to you, Dr. Ortiz. Thank you.
Thank you so much. Thank you, Mark. First of all, thank you so much for having me. This is a pleasure to be here. I've been an endocrinologist since the 90s, and I've been with Brown University. Right now, a partner of Diabetes and Endocrinology Associates of Rhode Island. So, yeah, we're going to be talking about diabetes. So I prepare a few slides just to guide us, and it's going to be a very general overview of everything from the definition, the statistics of diabetes. We're going to go into the guidelines, some advice, diagnosis, and then we're going to touch on therapy. And of course, any questions you have, please let me know. I am kind of bad at Zoom, so if I mess up, I'm sorry, but I'll try not to mess up on the Zoom. So, well, let me get started. First of all, what is diabetes? So diabetes is chronic, unfortunately. It's very prevalent, and it affects how the body metabolizes the carbohydrates, and carbohydrates are energy. So there's a problem there. So it could be either because the pancreas just doesn't produce insulin and we need insulin to lower the sugar, or it does produce insulin, but it doesn't work well. So this little diagram here help us a little bit. So when we eat, what happens is, well, all the food goes to the stomach where we start digesting our meals. And then, so the pancreas, the stomach starts sensing the carbohydrates. It starts noticing, okay, I'm getting so many carbs here. And it sends messages to the pancreas. And the pancreas in return produces insulin. Now, insulin goes in the bloodstream. At that point, the glucose gets broken down to all the way to the glucose, and it's already being absorbed in the bloodstream. And so in the bloodstream, it joins the insulin. So in the bloodstream, we have both glucose and insulin. Then it goes to the cells where it works, usually the muscle cells. And what happens is, so insulin will attach to a receptor in the wall of the cell. This would open a door for the glucose to go in the cell. So it's 1-to-1. So one insulin for one glucose going in the cell, and that's normal. That's the way it usually works. Now, let's talk a little bit about statistics. This here are the latest statistics that we have. Unfortunately, they're from 2018. So we have a prevalence. Prevalence means that the total amount of cases. At the moment, it's about 34.2 million of Americans, or that's 10% of the adult population, actually. 1.6 million of Americans have type 1, and the other 33 million is type 2, so mostly type 2. It is very prevalent as we age, unfortunately. So older than 50, about 1/4 of Americans will have diabetes. Now, incidence tells us about the new cases, and the new cases are about 1.5 million new cases of diabetes per year in the US. Now, this is compared to pre-diabetes. Pre-diabetes, we have 88 million of Americans after 18 years of age with pre-diabetes. And unfortunately, most of them, like 90%, don't even know they have pre-diabetes. So every time I get a chance to talk about diabetes, I like to stress pre-diabetes for those who have it, because, well, we'll talk more about pre-diabetes. A few words just about the cost, how expensive it. Those of you who have diabetes, I'm sure, realize how expensive it is. It is a very expensive disease. So in the US, it has an annual cost of about $327 billion a year. Most of this cost is from the direct medical services, direct medical treatments, diagnosis, evaluations, maintenance. But about 90 billion are because of reduced productivity due to sickness or complications from diabetes. Um, and according to data, we know that a person with diabetes will have about 2.3 times higher medical expenses than a person the same age but without diabetes. Um, this next slide is just to put it in perspective in Rhode Island. In Rhode Island, we have 80,000 um, adults with diabetes, or about close to 10% of adults, very similar to the national data. And again, according to the CDC, according to this, are not diagnosed, very similar to the national data. In addition, about 311,000, that's 41% of the adult population are at risk for diabetes. So this is where pre-diabetes comes, right? When it's not diabetes, but we see the risk like the weight, lack of physical activity, poor diet, poor habits, and then, it's an diabetes waiting to happen, unfortunately. So what types of diabetes do we have? Well, let's, of course, pre-diabetes, which we'll talk a little more soon. And then we have type 1. Now, type 1 is usually the young kids that those cannot produce insulin. Type 1 diabetes, their pancreas died, unfortunately. The beta cells, I'm sorry, of the pancreas that produce insulin died. So they lack insulin. And that's why type 1 diabetes needs insulin from day one. Type 2 diabetes, however, is mostly the adults, and it's more sedentary lifestyle, weight gain, and then we get type 2. Type 2, they do have insulin, they have a lot of insulin. However, it doesn't work well at the receptor level. And the way I like to kind of get an idea, you remember that cell we talked where the insulin attaches to the receptor? Well, those receptors get heavy and fat, and so the insulin cannot attach to it. And then because it cannot attach to it, then, well, it cannot open the door. So what happens, the pancreas produces 2 or 3 more times insulin to do the job of what lesser insulin used to do before. Um, that is a problem because a patient with type 2 diabetes is navigating with high levels of insulin. Insulin is a hormone that has other actions. Insulin by itself produces weight gain, promotes weight gain. So we have somebody who's already overweight and flying with high insulin. So we're promoting more weight gain. So we're kind of falling on a vicious cycle. Very difficult to break, unfortunately. Of course, the best treatment would have been weight loss, but it's not always easy to do, right? And there's a few reasons why. And we'll talk about that soon. The next type of diabetes is gestational diabetes. Gestational diabetes is when diabetes happens during a pregnancy. That is a very serious event. Diabetes in pregnancy could be very dangerous to the mom or to the fetus. Uh, Either one could have complications. So to the point that when a young lady gets pregnant and gets gestational diabetes, the treatment of diabetes at that point becomes extremely intense. We like patients to not only check in sugars all times a day, no, they need to call in their sugars sometimes daily. And we have a special nurse who talks to them in daily insulin changes because and sometimes they even remove their driver's license in case the sugar go low because it's actually better to keep it very low on, I'm sorry, within the very low side of normal as opposed to letting it go high. So even sometimes a sugar of 120 is not good for them. So that's a very difficult state to have. Other types of diabetes more rare. Well, we have surgical acquired. Patient, let's say, has pancreatic cancer, or for any reason they remove the pancreas. Well, that's a straightforward type 1 diabetes. I mean, the patient will not produce insulin, so it goes into diabetes right away, unfortunately. Some medications also could cause diabetes, like steroids, for example. People on prednisone, people who have asthma, who have chronic bronchitis, and they put them on prednisone frequently. Sometimes for arthritis, also they put them on prednisone frequently, and those will promote higher sugars. And those type of medications can make the patient diabetic right away. And unfortunately, a lot of our patients became diabetic through this way. Usually, this will be more like a type 2 diabetes. And then there's rare genetical forms like the MODY, MODY. Those are extremely rare cases. Those are genetical cases. There's diabetes, actually a newborn with diabetes. Those are very, very rare cases. But the vast majority, the ones that we study the most, the vast majority of diabetes is type 1, and for the most, type 2 is the most common. So this diagram kind of help us understand what type 1 diabetes is. As we said, the pancreas in type 1, the beta cells in the pancreas where insulin is made are dying. So the formation of insulin is very low. So very low insulin or none. But the patient unfortunately has to keep eating. So the glucose goes high in the bloodstream, and then none of it enters the cell because there's no insulin to open that little door. So what happens then, because glucose is not entering there? Well, the lack of insulin promotes other stuff. The lack of insulin in type 1 diabetes promotes breakdown of proteins. Those muscle proteins, they die. Breakdown of glycogen. So then they cause what we call ketoacidosis. So ketoacidosis is like acidosis in the bloodstream. And that's a very serious endocrine emergency. So that happens in type 1. So unfortunately, when a child suddenly, a previously healthy child, suddenly becomes losing a lot of weight, very thirsty, very tired, a lot of weight loss, and then suddenly nausea, vomiting, abdominal pain until he collapses. Family takes him into the ER and they realize the sugar is high. And usually they are in ketoacidosis at that point because they haven't been diagnosed. So the lack of insulin is severe at that point, and that's a medical emergency. Um, so, but ketoacidosis is typical usually of type 1 mostly. Now, type 2, as we said, it's different. Type 2, they do produce a lot of insulin. But the glucose still doesn't enter the cell, but it's not because of the lack of insulin, it's because in the receptor of the cell, there's resistance to that insulin. So high insulin promotes weight gain, and then leading to more insulin resistance. And as we said, it's a vicious cycle, very difficult to break at that point. This diagram represents a little bit what insulin resistance is. So on the top picture, we have normal. So you see the blue ones, the blue marbles here are insulin molecules, and the red ones are glucose molecules. So in any given receptor, we have one insulin attaching to the receptor for opening one door for one glucose going in. When we have insulin resistance, look at this. We're lacking those receptors, like this receptor is closed, this is closed, this is closed. They're not opening, they're not recognizing insulin. And so what happens, we're working with less receptors. So that's what we call insulin resistance. So the membrane of the cell, it just becomes resistant to the insulin. And that's why then the sugar goes high in the bloodstream. So on this table, I kind of have the gross differences. And this is not 100%, but it gives us an idea of the difference between type 1 and type 2. So let's start with the onset. So the age of onset, usually type 1, as we said, they're children or very young. So below 40, under 40. Whereas type 2, they're the elder who become like us, more sedentary, weight gain, poor diet, and we become type 2 or insulin resistance. Type 1, actually, they're thin. Those are thin children. Whereas type 2, well, elderly and overweight, more obese. The symptoms at the beginning of diagnosis on type 1 are very sharp and sudden. So this is, as we said, this is a child who previously healthy for the last 2 weeks can't drink enough, extremely thirsty, gets up in the middle of the night at all hours to pee, continues peeing and losing a lot of weight until he begins with the abdominal pain, nausea, vomiting, and boom, the patient is on diabetic ketoacidosis at that point. Now, versus type 2, the symptoms in the majority of the cases are none. When a person becomes type 2 diabetic, usually there's no symptoms. There's the only symptoms that the patient could have only in extreme cases when the sugar is extremely high. So then the patient will be very thirsty, getting up at night to pee 3, 4 times, urinating frequently, fatigue, blurry vision because the sugar gets trapped in the eye and it distorts the vision, and then uh, some weight loss, but still overweight. Um, but those symptoms happen when the sugar is extremely high, let's say over 300, 400. But type 2 diabetes happens so slow that the patient usually gets used to running 200 or high 200s, even low 300s. So the patient usually don't have symptoms with type 2. And that's the problem, right? Because the complications are starting, the damage that diabetes 2, type 2 does. They're going, but we don't know it. So another difference, insulin production. Well, the type 1, of course, doesn't produce any. Type 2, it says relative deficiency, only relative because it's not really a deficiency. And sometimes there's an excess. It's relative because it's not working. So who needs insulin? Well, type 1 needs insulin. Type 2 only later on, only if the diabetes was not well treated and we let it progress. And towards the end, when it's more severe, yes, the patient will need insulin, only to help the pills because insulin is the strongest thing we could take. And of course, type 1, we call it juvenile diabetes, and type 2, the adult onset diabetes, right? So how do we diagnose diabetes? And I also put pre-diabetes. So what's normal? A fasting blood sugar, not, oh, by the way, when we said for diagnostic purposes, we do not use glucometers. We want a true phlebotomy blood test from the lab, from the vein, because glucometers are not that precise, and it will be horrible to diagnose somebody with diabetes that doesn't have it, or vice versa, right? So we want to make sure it's from the lab. Glucometers are really good to give us an idea how you're doing, but not for precise diagnosis. So normal fasting blood sugar is 99 or less. And then we have the A1C. This is the first time we mention A1C. A1C, as you know, gives us an idea of how the sugar has been in the last 3 months, and it goes by different numbers. Normal is 5.6 or less. Also, 2 hours after eating or at any point, normally it should be under 140. So this is normal. Now for diabetes, a fasting blood sugar of 126 is diagnostic of diabetes. An A1C of 5.6 or more is diagnostic of diabetes. And any random blood sugar over 200 also is diagnostic of diabetes. And then we have the pre-diabetes. And pre-diabetes is, well, in between. So pre-diabetes would be fasting blood sugar of between 100 to 125, an A1C of 5.7 to 6.4, and any random sugar of 140 to 199. we were talking about A1C. So just to give you an idea, because the A1C, as I told you, go in different numbers. So when you, just to give us an idea, we said A1C of 6.5 is diagnostic of diabetes. Well, it turns out that an A1C of 6.5 means that the sugar has been on an average in the last 3 months around 140. So just to give you an idea what it correlates to. Notice that for a fasting blood sugar, diagnostic is 126, not 140, but it's because this A1C takes into account fasting over after eating, before eating, it takes into account every sugar and every minute for the prior 3 minutes, that's 3 months going backwards. So that's why it correlates to a higher number, right? This is one of my favorite slides actually today. Please remember this one. So for those who have pre-diabetes, when you have pre-diabetes, you truly are the fork on the road. And it's actually very easy, well, doable, to reverse it and become healthy. A little bit of weight loss. And I'm talking 5, 10 pounds. I'm not talking 40 pounds. I'm talking little weight loss may reverse it. But if we don't reverse it, then we go into type 2 diabetes. And then we become with the cycle. Remember, I told you more insulin resistance, promoting more weight gain, and it's very difficult to break. But when you have pre-diabetes, you could still break it. So if anybody has pre-diabetes, this is a chance to reverse it and abort type 2 diabetes. Please remember that one. That's and oh, one more thing, by the way, if you have pre-diabetes, could we give you medications? Yes, of course. We could give you metformin. But funny thing, there was a study done 2 years ago that showed that they put a group of patients on metformin, well, with pre-diabetes, right? So they put them on metformin, and then they told them, yes, and you need to do diet and lose weight. And here you go. We'll see you in 3 months. And there they go on their metformin. And then there was another group who did not receive metformin, but they did give him a dietitian and a counselor and a nurse calling them frequently. And on top of them, it's a very aggressive just diet. And actually that group had a higher incidence of losing prediabetes than the group on metformin. So what I'm trying to say, a serious good diet goes longer than the medication in this group, So what are the risk factors for type 2 diabetes? Of course, overweight. Um, the weight becomes a problem. Those receptors become more resistant. But then as we get older, we can become more sedentary, so age. Gestational diabetes, any lady who had gestational diabetes, it's a huge risk for type 2 diabetes. In fact, it's one of the strongest risk factors for type 2 diabetes, unfortunately. So if anybody had gestational diabetes, they really had to take care of their weight after they deliver the child, and don't become to that point of obesity, because they will become type 2 diabetic. And then, of course, other factors, family history, a bad diet, lack of exercise, certain ethnical and racial backgrounds. Well, unfortunately, some of us, like backgrounds like Mexicans, Mexican Americans, we do have a higher incidence of diabetes. Yeah, unfortunately, every race has their own. English has osteoporosis, and every race, but unfortunately, this is big on Hispanics. It's also big on Native Americans, by the way. But unfortunately, it's so frequent diabetes that is a risk on all of us. Smoking carries a higher risk. Stress carries a risk, unfortunately. Stress makes us make bad decisions with diet, with the lack of exercise. Stress drives us into an unhealthy lifestyle. So this will be the risk factors for develop type 2. So how do we prevent diabetes? So, well, again, if you have pre-diabetes, you have an excellent chance right there to abort it. Try to keep an ideal body weight. Try to eat a healthy diet. Stay active. Stop smoking, of course. Smoking has many risks, not only lung cancer, it causes bladder cancer, it causes an endless list of problems, right? So don't smoke. reduce stress. Go for walks. A walk is a good therapy, not only physically, psychologically. Exercise is a good psychological therapy. And then I put this website here. This website is from the CDC, and it's a series of videos actually by John London. And each video is about 5 minutes, and it has so many advices. They're going to diet, they're going to exercise, they're going to, oh my gosh, and anything you want to know. They have good advice on everything for diabetes or prevention of diabetes. One of them, and I picked this one, and they talk about the 5 steps of start moving. And this is for somebody with sedentary lifestyle. We cannot expect somebody who is a couch potato to go walk 2 miles a day. No, we had to go on steps. And any any increment on activity counts. Any increment on activity should be look at something positive. So, and this is 5 steps to get started. Like if you're watching TV, okay, but stand up and move around. Do some kind of activity while watching TV. Don't just sit, because the lack of, not only the lack of exercise is bad for us, but then also when we're just sitting and getting bored, then when do we have too much, right? So then there goes the diet. um, Take the stairs as much as possible. Don't take the elevator. But with this, also parking the car far away from the store. You go to the store, try to go park far away, walk a little more. Go outside. Going outside is great because not only again, not only the exercise, but it's therapeutical. I mean, it's for our psychology. Depression is a lot more common on people who are always indoors. People who get to go outside have a more alert, better perspective, right? So go outside, enjoy nature. They recommend dance around at home. Hey, if you like music, well, that's around. Dance, move a little bit. Why not? Why not? It's cleaning the house, start dancing. Why not? Walk, as we say, very therapeutical. You should walk, and they do recommend starting um, little. Don't, I mean, they say 30 minutes a day here will make a big difference. Yeah, some of us cannot do 30 minutes a day. They the American College of Endocrinology says if you cannot work 30 minutes a day, well, do it but you're able to work, well, walk an hour and a half, 2, 3 times a week. uh, when the days you can walk, the days you have time, and make it a little longer too. So it helps, it does help. So how do we treat diabetes? Somebody who already has diabetes, how would do I like to treat? This is the way, what I put here is the way I like to treat my patients with diabetes. Notice right away, medications are at the bottom. Medication should not be even considered till we address all the prior factors here. And the number one, my favorite, education. And that's why I'm here today, because the more education we get, the better. Education is your biggest weapon. Education is your biggest tool. So the more you can learn about it, the better. So I do welcome you to go into the, advise you to go into the CDC website that I put prior. Also, you can go into the ADA, the American Diabetes Association. They have a lot of stuff there. Um, and so those are good resources where you could just navigate and see a lot of education. If you see that they're giving a free talk, why not go for it? And education. If you have diabetes and your doctor says, well, maybe you should see a nutritionist. Some patients said, I already know it. I just mean, no. Go see what that person has to say, right? Why not? It's advice. And let the insurance pay for it, and go see what the nutritionist has to say. If we do it or not, that's a different story. But at least let's get ourselves educated as much as we can. Um, so number two, diet, of course. I do recommend seeing a nutritionist. I do recommend a healthy diet, 2,000 calories for the average adult, 18 to 2,000, 1,800 to 2,000 calories a day, with moderate, kind of low carbohydrates. And we'll have an example of carbohydrates coming soon. Um, walk, and remember the prior slide says walk 30 minutes a day. Well, the American College of Endocrinology, they say you walk as any way you can as long as you do 150 minutes a week. So again, you could do 150 minutes, that's 2.5 hours. So you could break it down any way you can. You could walk 2 hours one day, half hour another day, you're all done for the week. But any way possible, and as much as we can, why not? Prevent complications. Well, diabetes causes complications. We need to prevent them. That means we need to look for them in case they're starting. And we'll get into the complications soon. Get your yearly physical exam. Don't ignore the yearly physical exams. Why not? Diabetes is not a sugar problem. Diabetes is a general health problem. It affects everything. So there's some things that as an endocrinologist I may not catch because it's so vast. So go to those yearly physical exams. Eye exams. Diabetes is the number one cause of blindness, by the way. And unfortunately, it doesn't give us warning signs. Diabetes just makes us go blind like that. The only way you could prevent it is by having an eye doctor dilate your pupils and look at the back of the eye. That's the retina. That's where the damage happens. So somebody needs to look at the retina. So yearly eye exams are very important. Don't expect for symptoms. Your first symptoms may be blindness. And there's one rule in diabetes: whatever you lost, you lost. It's not going to come back. You lost your eyesight, unfortunately, it's not going to come back. Next one, foot care. Diabetes is also the number one cause of foot and leg and non-traumatic amputations. And it's because diabetes affects not only the nerves, but the circulation, right? The high sugars will clog vessels, and then the circulation gets impaired. And the feet being the farthest away from the heart, they suffer the most. So ulcers, gangrene happen a lot, unfortunately. Dental care. You know, high sugars will give you bad teeth right away, but bad teeth and bad gingivitis will give you higher sugar. So one makes the other worse. So make sure you keep your teeth healthy also. Mental health. Unfortunately, depression is very common in diabetes. Why? It's not that diabetes causes depression. No, it's the nagging care that diabetes demands out of us that causes depression. Because why do we need to check every day? Why do we need to take all this amount of pills? Why? And every day, every day. Why do we need to inject insulin? If not, why can't I eat that birthday cake in front of me? You know, it's so nagging. It's always a problem. So, elevates the stress, elevates depression, unfortunately. So make sure we address that. Make sure you stay with a healthy mind. Be prepared for emergencies, depending what your treatment is. If you are on insulin, make sure you have extra insulin on the fridge all the time. Don't wait till your last vial to call for a refill. Make sure there's always one or two extra vials, one or two extra whatever. Make sure you have enough test strips. Make sure you have enough glucose tablets for the low sugars or orange juice or something. Don't get into a low sugar without being prepared. Always be prepared for complications. Always be prepared for that, and be prepared. For what? For power outages. If you're on insulin, you need the refrigerator for your insulin. So always have those plastic ice things on the freezer in case of a power outage. You put them in an ice box with those ice, so you keep your insulin longer without problems. Um, then, of course, we talk about monitoring sugars, and we'll go into a few devices of how to monitor the sugar, and then at the end, medications. And I have a few words about insulin and medications if we have enough time. I notice I'm going a little slow, sorry. So what are the long-term complications of diabetes? And I put right away on red the number one cause of. So diabetes type 2 is the number one cause of blindness, as we said. It's also the number one cause of non-traumatic leg amputations, and the number one cause of kidney failure and dialysis, and also a number one cause of kidney transplants. And it's all because of a long history of poorly controlled glucose, right? It could also cause neuropathy. It causes heart disease, strokes, gastroparesis. The gastroparesis is the GI tract just doesn't move right. It just gets all messed up. the wounds won't heal, and of course, infections are common in high sugar diabetes. In this graph, this is one of the biggest studies ever done in diabetes. The DCCT trial was published actually in 1996, and it still is a hallmark here. And the study still is as accurate as it was back then. So diabetes has proven that the higher the A1C, the higher the chances of complications like blindness, renal disease, neuropathy, leg amputations, everything. So that's why the American Diabetes Association says to be well controlled, keep it below 7 to prevent those complications, right? Um, so once again, the number one indicator of more than your sugar, nothing, the number one indicator of how good or bad of prognosis we'll have for the future is the A1C. I'm gonna skip this. Talking about nutrition, we touched about it before. So we, of course, look at the carbohydrates. Oh, by the way, talking about carbohydrates, I should talk about this first. When you read the front, actually, when you read the front label of a product, ignore the front. Whatever they say, sugar-free, no sugar added, those are lies. Those are commercial lies. Don't trust them. You have to go to this. And these are some definitions from the FDA. So sugar-free, what does sugar-free means? Well, it means that it's less than half a gram of sugar per serving. That's not sugar-free. It means it's a little lower. Reduce sugar. Reduce sugar. So the FDA gives permission to food companies to put reduced sugar when they have 25% less sugar than the serving of the regular version of that meat of that food, right? So 25% less is still, I mean, of a cheesecake is still a lot of sugar. But anyway, so anything that has only 25% less, they could put reduced sugar in the front of that product. No sugar added. No sugar added does not mean sugar free. No sugar added means no sugar was added to what already came with it, right? So if you're eating, let's see, an apple pie and they say no sugar added in the apple pie, well, the apples have sugar and the crust has a lot of carbs. So I'm sure that apple pie is loaded with carbohydrates. Sugar alcohols. That's something you read in the label in the back. What is a sugar alcohol? Well, sugar is alcohol is a substitute, like an artificial sweetener, like the equal and those artificial sweeteners. Net carbs. If you read net carbs, well, net carb is not a legal definition from the FDA. There's some versions of net carbs, but it's not a legal definition, so that should not be there. We need to read total carbohydrates. That's what we should go by. And by the way, starting in January, this coming January, the FDA is going to add into the label added sugars. So they're going to see like this, sugars added on the label. When you see this label, and this is what I want you to see, you had to see, first of all, the serving size. What is a serving size? Because just because it says 230 calories, well, it could be 230 calories a teaspoon, not a glass, right? So we have to be careful on what's the size of that serving. And then this here on this side is the daily value. So what percentage of the daily value um, this is just talks a percentage, like, for example, this product will have 8 grams of total fat, which is actually 12% of the daily value required on the healthy diet, a 2,000 calorie diet, according to this, 2,000 calories. I don't want to confuse you. I'm not going to go more in depth, but I do want to make sure you look is total carbohydrates. And that's what you need to look, read. So whatever it says, when it comes to sugars, whatever you see in the front, any of these definitions, totally ignore it and go straight to total carbohydrates. That's the one you need to read. That's the one that's going to give you the most information. Of course, we look at the calories because we want to lose weight, so keep the calories down. But within those calories, how many of those are carbohydrates? Because that's what's going to raise the sugar, not the calories, the carbohydrates, right? So they recommend that you split your dish. This is a dish, and put half of it not starchy vegetables like broccoli. Excellent. Vegetable, green, not white. White vegetables like the potato, tons of starchy carbohydrates, which it's okay if we eat a quarter of it. And this represented here, a quarter of it, because we do need carbohydrates. So fruit is a carbohydrate. And by the way, anything that ends in "ose" is a carbohydrate, like glucose. Then we have fructose, right? And then we have lactose. So all those oses are carbohydrates or sugars. Careful. And then the other quarter, of course, we should have a protein, like a meat, like a chicken, like a fish, like and a protein. So what are the goals? Where do we want to keep? Somebody already has diabetes. What do we want to do? So according to the ADA, we want to keep the A1C below 7. We want to keep the fasting glucose between 70 and 130. Notice 70, because a lot of people with diabetes says, "Oh, I had a horrible low of 78." No, that was actually normal. Yeah, but I feel horrible. Yeah, because you're not used to it. Because that's what happens. We're used to being high, and the day we're normal, sometimes we feel like very low. With time, little by little, going down slowly, we do get used to being normal. Um, Now, they also recommend 2 hours after eating should be below 180, and low sugar is considered below 70. So these are the guidelines from the American Diabetes Association. But they're guidelines, they're not written in stone. There's another association, the American Association of Clinical Endocrinologists, who recommends A1C below 6.5. They've been criticized because to keep an A1C below 6.5, we risk more low sugars, unfortunately. So we have to be careful with that. But as long as we keep it below 7, we're good. Um, so just a little word about low sugars, because some patients tell me, "Oh, no, 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 I'd rather be high because I feel fine at 200, but I feel horrible, horrible, horrible under 100. So for me, under 100 is worse than most people." Well, actually, that's a wrong statement. What happens, again, that patient is not used to being normal. But keep in mind, every time that person is high over 200 or about 180, as stated here, we get damage to the vascular system. We kill a few vessels. And then the sugar comes down to normal, but then it goes up later the next day. And when it goes up, we kill more vessels, or we block more vessels on top of the prior ones. So whatever we damage, remember the damage stays. Whatever we lost, we lost. It's not coming back. So that's the problem with the highs. But the patient feels fine. It's asymptomatic, as we said. So that's the problem. If diabetes would have caused pain, if high sugar would cause pain, most of my patients will be better controlled, but it doesn't. It's asymptomatic. So that's the highs. Asymptomatic, chronic damage. Uh, Now let's talk about the low sugars. What happens? Well, I feel horrible. Well, let's assume somebody had a sugar of 40 or 30, and the patient fainted, had a seizure, and they called the ambulance, and it was a horrible thing. Everybody's crying, concerned, and then it takes a lot, but they gave him IV glucose and the whole thing. Then the patient comes out. Well, the event was horrible, right? Yeah, it was. I don't want anybody suffering that. However, there's no damage left behind. There's no damage. It just felt horrible and it had horrible symptoms, but there's no damage left behind. So as I tell patients, the reason they feel horrible is because they have a very healthy brain alerting them that the sugar is going down. So that's an alert symptom, so they could do something about it, but it's not damage. So that's the difference between the highs and the lows. This slide helps us understand a little bit about glucometers, or how do we check our sugars. And I'm going to have to speed it up a little bit here. So glucometers are the most common. We all have used that. Then we have a continuous glucose monitors, who are more fancy, right? Right now, there's commercials for the Freestyle. I don't have a picture for the Freestyle Libre here, but as you know, you put something in the back of your arm, that little disc, and then it goes to this other device, and you could see it even in your cell phone. You could see the sugar number. This young girl is using what we call the Dexcom G6. It's a specific continuous glucose monitor that goes to her cell phones, to her iWatch, and she could continuously see, without putting any device close to it, her sugar number. The advantage of this one is it has alarms. So an alarm will go off if her sugar is dropping or very high, so she could attend to it. And then we have other continuous glucose monitors that we attach to a pump. This is an insulin pump. And this helps the pump work more automatic. So it's getting fancier here. And then we go all the way to implantable ones. We could surgically implant this little thing here just under the skin in the arm. and then it would send signals to any iPhone or any phone or any iWatch, or and it also has alarms, right? So there's many ways to check it, but at least a glucometer. And I'm going to speed it up a little bit here. Just a few words about medications. We have a lot of pills for diabetes. We have a lot of medications, and we have a lot of studies coming out. And but a few things that we should touch on. And the first one that I want to touch is on metformin. Metformin gets a bad rap on the internet, right? There's always something on Facebook. Oh, metformin killed my kidneys. Metformin caused cancer. Metformin this. Metformin that. The truth of the matter, metformin is a wonderful drug. Metformin does not damage the kidneys. Metformin actually helps us protect the kidneys. In this study, it proved that metformin lowered by 32% any diabetes-related endpoint, like the end-stage renal failure. It was 32% less common in somebody who was taking metformin. Any diabetes-related death was down by 42%. Any cause mortality by 36%, or any fatal heart attack down by 50%. It's a good drug. Metformin also helps us lose some weight. And it helps us fight the insulin resistance of type 2. So metformin is a good drug. There is a problem with metformin, however. Of course, it may cause the GI symptoms, right? People who had been on metformin at one point experienced nausea, abdominal bloating, even vomiting sometimes, and severe diarrhea, right? Severe diarrhea, it could happen with metformin. We like to start slow dose, and low dose, and then increase slowly, and always with food in the stomach. That would lessen the chances of GI symptoms, but those are just symptoms. Those are not damage. But then if it's still with the patient with severe diarrhea, then forget it. We stop it. I don't want anybody suffering from any, you know, side effect from any pill, right? So, in fact, while we're saying this, one of my number one goals in my patients with diabetes, as I tell them, is their quality of life. I want all my patients to be happy. Why not? I mean, life is beautiful. I want them to be happy, right? But that has a cost. Good quality of life has a cost, unfortunately. So that means that do whatever it takes to save the eyes, the kidneys, the legs. Because if a patient is coming blind on a wheelchair because has no legs and going to dialysis every other day, there's no quality of life. So, but if the patient after 50 or 60 years of having diabetes comes walking, talking, moving, and looking fine, and so that's wonderful. That person is beating diabetes by that. That's how we beat diabetes, but by not letting diabetes take away our organs like our eyes or our legs and stuff. So quality of life is important. I'm going to skip this about a few other pills that I was going to talk about, but in the interest of time, and I'm going to go straight into insulin. So insulin in type 2, insulin for type 1 is in 100% of the patients. Type 2 only in severe cases when we need something more potent. It's usually after we try, the patient's already on 2 diabetic pills and the A1C above 8. So we start with 1 shot of insulin on top of the pills. And if that's not enough, then we start adding other insulins. And there's many regimens to treat, right? So there's many types of insulin, but the type of insulin has to do with the duration. We have rapid acting insulin. We have short acting, like the regular. We have intermediate, like the N, and we have long acting. And then in the long acting, we have a lot of new insulins, like the Levemir. Now we have Basaglar, we have Lantus, and others. This diagram kind of gives us an idea of the length of the insulin. The rapid acting is like the Humalog or Novolog. It acts really well, so it actually mimics the spike we get with the meals. Regular it was the short acting 20 years ago. It was the shortest acting we had back then. Now we have Humalog. So Humalog, Novolog, the Apidra, those are better insulins than regular. Intermediate, like the NPH, it was the long acting we had back then. It's the green line here. And notice it lasts 12, 14 hours. Now we have longer ones, like in this last one, here's Glargine, that's Lantus. It lasts 24 hours, so it gives us a nice basal insulin. This is a diagram here, and I don't expect you to read it, I know. This is the just to show the insulins that are available at the moment, or the combinations of insulin. This is one of the most common way we treat diabetes, and that when we want very tight control, very aggressive insulin regimen, we give a slow acting at bedtime like Lantus, and it covers baseline. And then before each meal, we get a rapid acting like Humalog to cover for the spikes of the meals. And we can titrate doses, but this puts the patient in 4 shots a day. Um, but it's the most aggressive way to treat it when we're treating with without a pump. Of course, a pump will be more aggressive. Um, a good old fashioned way to treat it is by keeping the mixed insulin like 70-30, they call it. So 70-30 will have about 70% intermediate acting, like the N, about 14, 16 hours in length, and then 30% of quick acting. In this case, it's regular, but we have better ones with Novolog or Humalog instead of regular. And what it does, if we can inject this twice a day before breakfast and before dinner, and it covers well, but not as well as this. Anyway, so I'm going to stop here in the interest of time. I notice I took a long time. I apologize, but I'm welcome to answer any questions you might have.
No, that was great, Dr. Ortiz. I know I certainly learned a lot, and I'm sure there's a lot more that we could talk about today. A couple of questions we've had come in. One is, in a case of type 1 diabetes, how would someone increase their insulin?
Oh, good question. Good question. So, type 1 diabetes, the good thing about a type 1 diabetes, usually it's a young person. Usually it's somebody with computer knowledge, right? So, right now, anybody below 40 was almost born with an iPad in their hand, whereas I know, of course, not that good. Right. So, that gives them a lot of advantages. That means they feel better with pumps, for example, because a pump is like a mini computer, right? So they could play with that, and they feel okay about making calculations on doses and more aggressive. There was a study also where we put a patient on like the long acting, and the study told us that a person who is intellectually capable could manage their own insulin doses following a few guidelines. And there's guidelines that we could give patients. And I do have patients with type 1 that I tell them, okay, we're going to follow these guidelines. And they do well, and they could adjust the long acting and the quick acting. We also give them calculations on the boluses, like for example, the Humalog before meals, instead of saying, okay, take 5 units before meals. No, we tell them you're going to take 1 unit per every 15 grams of carbohydrates before each meal, plus a correction, let's say, of 25 per every 25 of glucose, about 150. So that's an equation right there. It requires some mathematical work. But however, these kids could do it. And I seen kids in the single digits, like 8-year-old, 9-year-old, on an insulin pump. And I see them do those calculations and they're flying perfectly good. Yeah.
That's pretty remarkable. It sounds like in a way it's probably better now than it's ever been for a young person with type
Yes,
1
we
diabetes.
we we now have a lot of toys we didn't used to have. Like you saw all those ways to check sugar, for example. And the pumps are getting smarter now. The insulin pumps are actually smarter. They control our basal rate of insulin without us telling them what to do. So yeah, the more fancy toys to play with. Yeah.
Another question we got along the way was, is it possible to be cured of diabetes?
Okay, so unfortunately, type 1, no. True type 1 diabetes, no, because the beta cells are dead from the pancreas. There's a lot of studies, and about 10 years ago, there was this study that came out that said that they could actually make beta cells. They could do them at the lab, artificial beta cells. The problem is they cannot regulate them. So those beta cells, when they're given to a patient, they just produce insulin without any control. So it becomes worse. So that they have to, the problem is in the regulation of that. When we learn how to regulate those beta cells, then that will be a cure for type 1, but we're not there yet. Now, type 2 is different. Type 2, yes. So type 2, usually somebody has the gene for it, and something turn on the switch. It's usually it's weight gain as we get older and sedentary and eat junk and Grubhub and all that, right? So then that turns on the switch, but we could reverse it. Like, remember that slide with the fork in the road? That's how we reverse it. So a little bit of weight loss goes a long way. And studies have proven again and again and again that even somebody who already has type 2 diabetes, a little bit of weight loss will do drastic improvements in their A1C or their medication needs. So we could get to the point of no medications. And I do have a few patients who came to me on insulin or pills, and now they're I never stopped calling them diabetes, but we call them diet control diabetes, and they're doing perfectly well on diet only.
Excellent. Very good. One question I had, you mentioned early in the presentation the large number of people who have prediabetes and aren't aware of it and don't know. What could someone look out for? Is it a matter of just making sure they go to their annual physical and have those blood tests done, or are there signs that somebody can watch out for?
So with pre-diabetes, there's zero symptoms. There's no symptoms. If a patient is having symptoms like we talk, like urinating a lot, very thirsty, weight loss, blurry vision, fatigue, those are symptoms of really high sugar. At that point, the patient is not pre-diabetic. The patient is very diabetic at that point. No, but with pre-diabetes, there's no symptoms. So one way to do it, of course, is yearly exams, right? Look for that fasting sugar 99 or less. You could also, your doctor could do an A1C yearly also. Look for that A1C of 5.6 or less. And so look for those things. But, I had so many patients who came to me that when I asked them, when were you diagnosed? Well, it was about 10 years ago that I was not diabetic, but I had a touch of sugar, a touch of this, or I had just a little on the border. No. Don't take those. Let's go by the definitions, right? If a doctor tells us, well, you have a touch of sugar, no, how much was my fasting sugar? And if it's above 99, it's not a touch, it's pre-diabetes. That's the only
Interesting.
way, unfortunately.
Sure.
And that's why they go so many people undiagnosed, because there's no symptoms. It's just the lab value. Yeah.
Interesting. Well, that was great. A lot of great information, Dr. Ortiz. Thank you so much for being with us today and for sharing this presentation. I want to thank our audience who attended and joined us. Thanks for all the great questions. We're going to do this one more time, actually, next week, next Friday, November 6th at noon. We'll be back for our final Healthy Conversation series. And then the following Saturday, November 14th, of course, is World Diabetes Day. We will be here all day with tons of great programming, and hope you can join us. You can learn more about it and sign up to attend at riwdd.org. So thanks again to Dr. Ortiz and for everybody for joining us, and enjoy the rest of your afternoon. Take care.